below 1 year. In this chapter, we have different entities. We have diffuse large B-cell lymphoma, which is by far the commonest one. We have mantle cell lymphoma and Burkitt lymphoma, which we will deal with. Primary mediastinal B-cell lymphoma is actually a special type of diffuse large B-cell lymphoma, so most of what we will discuss about diffuse large B-cell can be applied to primary mediastinal. And high-grade B-cell NOS we see entering the differential diagnosis of diffuse large B-cell lymphoma, being a new category introduced in 2017. Now, diffuse large B-cell lymphoma can be, first of all, distinguished into the not otherwise specified subtype. And actually, when we say diffuse large B-cell lymphoma, the LBCL, we actually mean the NOS type, which is the majority of cases. All the other specific types, so one is, let's say, a wastebasket of whatever we cannot fit into the specific categories. Specified types are actually still diffuse large B-cell lymphoma, but with very specific features, which can be given by tissue location, like primary cutaneous DLBCL. It's called leg type. It was mostly presenting in lower limbs, but it's actually a cutaneous diffuse large B-cell lymphoma. Other location can be primary CNS diffuse large B-cell lymphoma. Can be, for example, a very particular intravascular large B-cell lymphoma, in which the tumor, even though still referred as lymphoma, is not making masses, is not really presenting with leukemia. So you don't count blast in the peripheral blood, but the tumor, when you examine the biopsy, is just located inside small capillaries, sinusoids, and so on. Furthermore, can be association with a virus, for example, EBV positive DLBCL, just NOS, but with EBV is defining a specific subcategory. HHVA DLBCL NOS, very similar, or the presence of a specific oncogene, anaplastic lymphoma kinase positive large B-cell lymphoma. So different features can be clinical, can be pathobiological, so tissue site of presentation, presence of pathogen, or rather presence of an oncogene. Those are specific types. Common feature of diffuse large B-cell lymphoma are, as by the name, the diffuse growth pattern, so it's not nodular, it's not marginal zone-like or whatever, it's just diffuse, effacing the entire structure of the tissue. Cellular population is large-sized, usually more than 20 micron. Can present, even though most commonly in elderly, so the median age of presentation is 60, can be present at any age from children to elderly, little bit more progressive than follicular, for example. You remember, median age is relatively similar, but in follicular lymphoma, most cases were above 45. Here, the 50% presenting below 60 years can spread up to children. Can present clinically as a primary disease, so de novo diffuse large B-cell lymphoma, or as diffuse large B-cell secondary to an indolent non-Hodgkin lymphoma or Hodgkin lymphoma, as we will see. We got the example of follicular and marginal zone lymphoma. Primary site of presentation can be nodal, you see 60%, or extranodal, so very common to have diffuse large B-cell presenting as tissue effacement in lung, skin, intestine, and wherever. Despite being aggressive and quickly proliferating, as I mentioned already a couple of times previously, it's curable. So aggressive means that without treatment the prognosis is very bad, but on the other side, the curability is higher than for indolent lymphoma. So roughly 50% at least of cases can be cured for our conventional chemotherapy for drugs plus the monoclonal antibody. How do we subclassify the LBCL NOS? We mentioned primary versus secondary, This is relevant, yes. Why? Because in the past we were used to think that secondary were behaving badly, more aggressively, especially more resistant to treatment. Actually, some recent study showed, actually a big one from the Italian lymphoma study group, that there is not really a big difference if we put them on the same level. However, secondary, as you can imagine, after years of an indolent lymphoma, most often patients are affected by higher comorbidities because of the time, the exposure to chemo, the immune suppression due to the lymphoma itself. But if you treat them for the first time, they are relatively similar. Of course, if you treat with 10 lines of chemo a follicular lymphoma and then it transforms, it's obvious that you cannot use the same chemo again, so the prognosis is much worse. We can use morphology. Morphology actually is not relevant for prognosis, but it's very relevant for the differential. It's a common tumor, is affecting quite often extranodal sites, so the morphological variants can put challenges in the pathologist, because similar to even to solid tumor. We will see that the most important today is the cell of origin, which can be defined better by molecular biology, but sometimes you are obliged to use immunohistochemistry as, as a surrogate. The most common morphological pattern that we encounter in diffuse large B-cell lymphoma is the polymorphic, meaning that we have large cell, we have a diffuse effacement of the tissue, but the morphology of single elements can be variable, can be resembling like this one, a centroblast, most likely, can be a little bit more like an immunoblast. Here you see in periphery the nucleus and the abundant cytoplasm. However, when 50% at least of the neoplastic elements do present specific features, we can have, let's say, specific variants. Can be, in fact, centroblastic, when the majority of cells resemble centroblasts. Here you can imagine this is happening quite often in secondary forms transformed from follicular lymphoma, for example. Can be the multilobated, in which the nuclei are lobated, so they are resembling multinucleated cells. You see in a couple of days the differential with Hodgkin lymphomas. Can be immunoblastic or with plasma cell differentiation. Plasma cells are a little bit more mature, so we have a pattern of more mature cells with smaller nuclei on the peripheral side of the cell and abundant cytoplasm, like this element, for example. Immunoblasts are a little bit more immature, but clearly going toward plasma cells. You can recognize here those elements with peripheral nucleus and the abundant basophilic cytoplasm. However, the nucleus is much bigger, and especially the chromatin is much more opened up, and there is a very big evident nucleolus. We also have an anaplastic morphology. I stress the fact that anaplastic morphology is important to remember. Why? It's not common, but when you have anaplastic morphology in a lung or in the intestinal tract, you can guess that in peripheral centers not used to see lymphomas, this can be easily regarded as an anaplastic carcinoma. And as such, for example, in the temporary biopsies, you would suggest the surgeon to take away a piece of the organ, which would be a big mistake because the only way to cure those patients is chemo, not surgery. Very similarly, and even with more specific feature, we have the epithelioid. You see, honestly, I would never think of lymphoma as first looking at this light. It is very large, like polygonal, abundant cytoplasm cells, clear cells, and even signet ring-like with a peripheral nucleus, very white cytoplasm, very optically empty. Those are really resembling solid cancer. Rosetting, when you have big cells surrounded by reactive elements like T lymphocytes, we will see the phenomenon in Hodgkin lymphoma, but can happen also in other solid cancer. So very important to remember that the commonest lymphoma can present with morphological feature that can be easily confounded with solid cancer. So quite important to go to immunophenotyping to recognize the lymphoid origin of the malignancy. And concerning immunophenotype, what we recognize are CD45, which we also call it as common leukocyte antigen. It's very widely expressed among hematopoietic cells. So if you just need one marker just to discriminate epithelioid, sarcoma, and hematopoietic, you can use CD45. And more specifically, B-cell markers. Diffuse large B-cell lymphoma, as you can imagine from the definition NOS, so a little bit of wastebasket, cannot be as consistent as follicular lymphoma for the phenotype. However, B-cell markers are all retained in general. So CD19, 20, 22, and 79A, they are all present. There are immunoglobulin that can be either on the surface or in the cytoplasm, according to how much differentiated and well assembled is the cell. Ki67, the proliferation index, is generally high, but quite variable, varying from 30 to 99%. This 99% can appear bizarre. You will understand today why we have a specific entity which is 100% proliferating, which is not diffuse large B-cell. So usually you tend to define up to 99. Of course, we don't count up to 99, just meaning that a few cells can be not cyclic. Other markers, usually representative of the precise differentiation stage of our lymphoid cell, are variably expressed. So we have germinal center markers like CD10 and BCL6. Rather, we have IRF4 as marker of, let's say, tendency to exit the germinal center, CD138 as a marker of plasma cellular differentiation, and other markers just meaning kind of cellular activation like CD30, which is mostly important for differential diagnosis, and nowadays, because we have a monoclonal antibody, but it's not officially approved for the treatment of diffuse large B-cell, so it's mostly for differential diagnosis, you'll see with Hodgkin lymphoma. And BCL2, which we know very well now as anti-apoptotic protein, which can be expressed in selected cases of diffuse. But going to the image to see it clearly, CD79A, you can easily appreciate, I think, that all these big cells, rather than the small lymphocytes that probably are infiltrating T cells in this image, they are of B origin. So even though the cell is big, is not nice looking, you can recognize it as B lymphocyte. And as in parallel to the expression of surface molecule, we also have the expression of PAX5, just to remind you, the master transcription factor for B cells, very early appearing in the development after early lymphoid progenitors are committed toward B cell fate. What about CD20 as a diagnostic marker? So let's say something more, and generally speaking, not just referring to diffuse large B-cell lymphoma. I showed you that we have different markers that we can use as marker of B cells, CD19, 20, 22, and 79A. And CD20 is very nice because it's also a therapeutic target. But is it also so consistent and valuable as diagnostic marker? Here I'm carrying an example of bone marrow biopsy in which immunohistochemistry was used to confirm the presence of diffuse large B-cell lymphoma. You can see scattered large cells positive for CD20, so those are not normal B lymphocytes in the bone marrow. Here you can see a plasma cell, for example, just to be familiar with the images. We have a couple of mitosis, so tumor is supposed to be quite aggressive because here we have, I don't know, 20, 30 cells and 2 are proliferating. However, since being positive, the bone marrow of these patients, so stage 4 bone marrow, we need after treatment to do restaging and bone marrow biopsy to see whether we could clean up the bone marrow from neoplastic cells. We would be tempted to use CD20 again as a marker to assess the presence of cells. However, you should keep in mind that since we are using a treatment against CD20, neoplastic cells are unfortunately smart enough to downregulate CD20 after treatment. So CD20 cannot be used at the restaging. So for diagnostic purposes, it's not the best, first, because it's not the most reliable antibody on tissue, but second, you cannot use in biopsies following the treatment. So remember, they are CD20 positive, but CD20 is not the marker that we prefer to use in diagnostic. This is the example of diffuse, but of course, any B-cell lymphoma treated with rituximab would experience the same phenomenon of downregulation. Most likely because CD20 is not relevant for the biology, for the life of neoplastic cells. Here is CD45, the common leukocyte antigen, very clearly positive in diffuse large B-cell, and here CD22, so that we can use as an alternative marker to define the B-cell lineage. I mentioned already once the concept of monotypic versus monoclonal. When you see a monotypic light chain, so everything is kappa or lambda. Of course, here I'm referring to the large cells. I don't care at all of what the small lymphocytes are, because they are normal lymphocytes. The population is defined monotypic. I can test at molecular level the immunoglobulin rearrangement. I can bet that all those red cells, they carry the same rearrangement, so they are monoclonal. But this would be a very quick investigation to document that the population is abnormal. Here, Ki67, very high in this picture particularly, but you can see that some elements here and there are probably bad looking but not proliferating. So let's say 95%, so not 100%. So morphology, immunophenotype. Let's move to the genetic of diffuse large B-cell lymphoma. And in the last 20 years, we have been learning that molecular genetics is quite important to define the prognosis of diffuse large B-cell. To make a long story short, I will tell you that using gene expression profiling, so a technique that allows us to study the entire transcriptome in a given cell sample, cell population, whatever we are testing, in the same experiment. So differently from qPCR, that you certainly are aware of, and immunohistochemistry, where you study one by one. I studied BCL2, I studied CD20. Here, I study the whole transcriptome, so I can check which genes are expressed, which genes are not, and I can compare different samples in terms of expression. So you will see that some samples do overexpress something and downregulate something else. And by testing a series of diffuse large B-cell lymphomas that apparently were all just the LBCL NOS, nothing special in one and the other, it was recognized that actually they constitute two discrete subgroups. Here, every column is a sample, every row is a gene. And the coloring system, when you have red, is meaning that you are overexpressing, in the green you are down-regulating. So here we have a group in orange overexpressing a series of genes. By looking specifically which genes are those, it was found that they are the genes commonly expressed by germinal center B cells. And this group would define germinal center B-like. On the other hand, another group, you can see no genes of the germinal center were expressed, but a series of genes that initially were recognized as genes expressed by activated peripheral blood B cells, and so the group was defined activated B cell ABC-like group. More recently, we found it's not ABC, actually, it's not activated B cell, but still different subset of B cells. What is important is that with the same treatment, the prognosis of the two groups, you can clearly see, was totally different. 20% survival rate for activated B cell-like, 60 abundant, even 70% survival. This is before rituximab was introduced. Just with chemo, more than 60%. So totally different with the same morphology, apparently the same phenotype, at least the phenotype that we used to study at that time. And so by time we've been learning that there are two discrete subgroups that we call GCB, DLBCL, actually deriving, I would say corresponding, you remember the difference between cell of origin and cellular counterpart. So they correspond to germinal center B cells, we call GCB, and some samples that actually correspond to something in between the germinal center and plasma blasts, which is ABC-DLBCL. 50 to maybe 25, 30% of cases, we do not assign to either group. They are quite heterogeneous, not corresponding to a normal counterpart, and so we call them unclassified. Importantly, unclassifiable, they behave badly like ABC lymphomas. So not only we don't know what they are, but they are also difficult to be treated. However, it's difficult to study the whole transcriptome in the routine diagnostic. As you can imagine, you need an expensive machine, especially you need expert people in doing the algorithm to classify tumors. And so it was tried whether immunohistochemistry could make a surrogate technique for that. And in fact, if you test germinal center markers, like CD10 and BCL6, they turn out to be positive. Here is just control with BCL2, but we will talk about BCL2. Now, focus on germinal center B-like markers. They are positive. This is an example of GCB. You remember that BCL6 is expressed in the germinal center and does not allow a cell to progress to plasma cell. However, after T cells, they recognize our lymphocyte to be ready to progress to plasma cells. IRF4 expression is induced by CD40 signaling and an FKB pathway. An FKB is not only in tumors like marginal zone lymphoma, but an FKB in the biology of lymphocytes. IRF4 will in turn repress BCL6, so cells will be free to express BLIMP1 and become plasma cells. So we can study IRF4 as a sign of differentiation outside germinal center, and we can see that IR4 and the plasma cellular marker CD138 are positive in ABC, like diffuse large B-cell lymphoma, while BCL6 and CD10 are negative. So very easy. We use 3-4 markers to make the classifier, as was proposed by a German group in early 2000s, in 2002 actually, paper in Blood. However, you can see already from the image that the difference between the two groups in terms of prognosis was not as evident. And indeed, immunohistochemistry is not able to provide an as effective tool as molecular biology does. Several different classifiers, changing the order of testing, adding 1 or 2 molecules, were tried, but nothing can be as effective as molecular biology. In this regard, I know that there are pathologies, they claim, oh, there is no big difference. I would like you to think with your own mind. If I test 25,000 genes, even though if we reduce to 2,000 the expressed genes in a cell, or you test 5, do you think you can never have the same amount of information? 2,000 molecules versus 5. I think it's quite obvious it's not the same amount of information. You can be reasonable to reduce in order to be practical, but you can never have the same amount of information if you test everything and if you can test only a few things. Very luckily, technology helped a little bit. Now we have a machine, it's called nanostring technology, that allows to study roughly 20 genes, just the RNA, which can be taken even from formalin-fixed paraffin-embedded cases, so the routinary cases that we have in pathology, that we can find in archives, and is able to, I wouldn't say correctly 100%, but very reasonably assign cases to either ABC or GCB groups. This is a machine that has been recently associated to clinical trials, meaning that new drugs that are under approval for diffuse large B-cell lymphoma, they might require this specific test to be to be made available in the clinical practice. So if you want to give a new drug specific for ABC DLBCL, you need to demonstrate that this is an ABC DLBCL with this machine, not with immunohistochemistry. So this will be a little bit a big revolution. The same technology, just to make a parallel, probably you studied last year, I hope at least, can be used. The test is Prosigna for breast cancer as a surrogate of mamma print, the molecular test, FDA approved, but mamma print, you have to send the sample to somewhere, to a service. Prosigna you can have in your hospital. So good pathologists, they do have the machine to do Prosigna. They don't need to send samples abroad, okay? This is the same, the lymphochip will be used for lymphomas. And as further confirmation that ABC and GCB are somehow different, if you go back to WHO classification, okay, they are very similar. They are analog in morphology, but already the phenotype is somehow different, even though not so reliable, is somehow different. The molecular profile, the transcriptome is different. Clinically, they are different. They behave differently under chemotherapy, but also on the really genetic point of view. So we have different mutations. Some are in common, but some are really specific for one or the other group. I don't need to enter the details. It's important for you to know that they have a different genetic background. So they are probably two different diseases that are currently grouped inside still a wastebasket as diffuse large B-cell. And among different genes that can be found to be mutated in either one group, we have genes affecting the BCR signaling, and particularly the downstream pathway of Bruton tyrosine kinase, and NFKB. Once again, NFKB is necessary for survival of ABC diffuse large B-cell lymphoma. And how can we translate this into clinical practice? Well, because we have drugs that can inhibit the Bruton tyrosine kinase, and generally speaking, the downstream of BCR, or can inhibit NFKB. Actually, bortezomib is an NFKB inhibitor through inhibition of the proteasome, was the first drug approved for ABC diffuse large B-cell lymphoma, specifically after a clinical trial using nanostring technology. Other features in the genotype. Of course, we have clonal rearrangement of immunoglobulin, we mentioned. It's important. In diffuse large B-cell lymphoma, we have a complex karyotype. So many lesions is a complex disease. And among other, we have deletion of TP53 that confer a bad prognosis, and rearrangement mutations of BCL6, BCL2, and MYC that we can now start learning that are some key genes in the biology of lymphomas. Concerning MYC, MYC is a huge oncogene because it's a transcription factor regulating 15% of the human genome. So you understand that switching on and off MYC will change completely the transcriptome of a cell. MYC is particularly determining high proliferation rate in cells, cell growth, and increase protein synthesis and activate metabolism, both glucose and lipid metabolism. Actually, it's translocated in 10-15% of diffuse large B-cell lymphoma, and the partner can be either an immunoglobulin, as we are used to see now in many lymphomas, we have immunoglobulin as partner for translocation, you remember why, but very commonly they are non-IgH partners that include BCL6 itself, PAX5. Just note, genes that are mutated are quite frequently expressed genes because you need an open chromatin for lesion-making machinery to assess the gene. If the chromatin is closed, you cannot translocate anything, right? Overall, it was associated to an adverse prognosis, but I wouldn't say it's per se, it's because it's usually associated with other bad features. First of all, being BCL2. BCL2 is an anti-apoptotic protein. You remember, in an indolent lymphoma, quite often apoptosis impairment is the first event. So the tumor actually is slowly proliferating, but always surviving. This is an indolent disease. Now imagine that you have a highly proliferating tumor and you just turn BCL2 on. So the cells cannot die anymore. This is a terrible machine now, because you have high proliferation and no death, even under chemotherapy. So of course it's a bad prognosis. This is going to happening in 20 to 30% of cases, usually germinal center be died. But be careful, this is translocation of BCL2. So the same event we have found in follicular lymphoma, indeed there are some authors, even good ones, and I'm not sure, I'm very far from them, that consider BCL2 translocated diffuse large B-cell lymphoma as a secondary diffuse large B-cell lymphoma in which we couldn't recognize follicular lymphoma first. But you can have BCL2 also expression, and we will see BCL2 expression is definitely common in ABC diffuse large B-cell lymphoma. So when you find BCL2, it can be due to translocation in germinal center B-cell lymphoma or other mechanisms, microRNA, whatever mechanism, in ABC mostly. Third of the list, we have BCL6. BCL6 is a master gene in germinal center, is the most frequently mutated gene in diffuse large B-cell lymphoma, up to 30%. Can be mutated, and mutation, especially in the promoter, will not allow BCL6 to be shut off by IRF4. So BCL6 will just work and work, maintaining the cell inside germinal center. And if you remember, germinal center is a very dangerous reaction because you have ongoing somatic hypermutation. So if you don't allow cells to go out, sooner or later they will accumulate genetic events. BCL6 can also translocate, and is called, defined like a promiscuous gene, because can translocate with many different partners, one of which being MYC itself. So they can do a mixed translocation. Altogether, those translocations can confer a bad prognosis when they are associated. And in the last edition of the WHO classification, not WHO translocation, we did have the description of new entities. New entities that we call high-grade B-cell lymphomas with MYC and BCL2 and or BCL6 rearrangements, which we can also define double hit or triple hit, meaning that you need translocation of MYC and usually translocation of BCL2, sometimes translocation of BCL6, sometimes translocation of all the three. Those are not considered anymore diffuse large B-cell lymphoma NOS, but a special category provided with a particularly bad prognosis. Based on the morphological feature, we can also have a grade B-cell lymphoma NOS, in which the morphological features are something in between, Burkitt lymphoma, which we will see very shortly, and diffuse large B-cell lymphoma. So it's difficult to define by morphology. It's not properly diffuse, but there are no rearrangements. Based on that, you understand that when dealing with diffuse large B-cell lymphoma, nowadays it's important to use not only immunohistochemistry, but also FISH to detect translocations, because the presence of translocations would define new categories provided with a worse prognosis. Those are survival cures for general population of diffuse large B-cell lymphoma and double-hit lymphomas, particularly the MYC BCL2. They have a particularly bad prognosis. Once again, MYC promotes a huge proliferation. BCL2 doesn't allow cells to undergo apoptosis. Patient will die shortly. This is the message. What if we use, once again, immunohistochemistry as a surrogate? You don't want to perform FISH. FISH is expensive. It's almost 300 euros for test. Time consuming. Technician working almost 2 days. So why not doing immunohistochemistry? We can check the protein expression. Well, you can do it, but this is not a surrogate, acceptable, because double hit are defined by genetics. You cannot define double hit by expression. Indeed, if you can only document expression of BCL2 and MYC, but not document the translocation for any reason. You don't test, you fail, they are negative. So you have expression, but the reason for expression is not the genetic rearrangement. You call them double expressor. Is that anyway biologically meaningful? Yes, it is. They are provided anyway with a worse prognosis. Here, the situation is a bit complicated because MYC expression can be variable, and the cutoff to define MYC expression is not yet, let's say, there is no agreement about researchers. Someone, they claim you need to have 70-80% of MYC expression. Others, of course, the standard 30. So the curve is a little bit different from that one of translocation, but still is something we can do. So practically speaking, you first test immuno. If positive, you go for fish. As mentioned, we have several subtypes. Overall, they are diffuse large B-cell. Can be either GCB or ABC. In this case, they are more consistently. One type, for example, leg type tend to be ABC and so on. Overall, similar features, but a little bit more specific. Unfortunately, we don't have time to enter details. Any question about diffuse large B-cell? I'm rushing a little bit, but we have to make dense in 2 hours all the aggressive lymphomas. So. We have to do with what we have. Well, if there are no specific questions, we can go ahead with Burkitt lymphoma. Burkitt lymphoma is not common. If you remember the first slide from today's presentation, Burkitt lymphoma is barely reaching 1% of all lymphomas. So why worrying about Burkitt lymphoma? It's not so common. But actually, Burkitt lymphoma is epidemiologically very relevant because it's the commonest cancer in childhood in Africa. And is furthermore a very nice example of multifactorial pathogenesis to understand how lymphomagenesis works. Here you can see a couple of maps where you can see the incidence of Burkitt lymphoma in peri-equatorial areas, mostly in Africa, but generally speaking, peri-equatorial areas. And here, in some serious, Burkitt lymphoma is reaching in such regions 70% of children cancer. Burkitt lymphoma is a very aggressive tumor. Indeed, some authors even propose to call it very aggressive, not just aggressive, because the doubling time is within 48 hours. So it's really, really amazing how quickly the tumor can grow. So if you don't treat, of course, it's lethal in a very, very short time. For this reason, it can bring a patient in Europe, in US, very quickly to the clinic because it's growing fast. If the lymph nodes are superficial, if the disease is visceral, usually you have an advanced disease. But the tumor is very common in developing countries where going quickly to a doctor is not an option. And so doubling time is fast. Very often those young patients do reach the hospital in an advanced stage anyway, even when the disease is superficial. And not only the stage is advanced, but often the disease is presenting as bulky disease. Have you defined the bulky disease in hematology already? No. Bulky means big, huge, very simply speaking in English. However, in hematology, the significance is a little bit more selective. There are different definitions. In the past, bulky was defined in the mediastinum, a big mass taking more than 1/3 of the lateral diameter in the X-ray, the conventional X-ray. Just can be applied only to the thorax, so maybe not the optimum. Then was 10 centimeter, 12 centimeter. Honestly, I don't understand why 12. 10 centimeter is already a big mass. Biologically, the reason is when the mass is so big, chemotherapy does not reach the center of the lesion properly. So I don't think there is need to find very fancy definition. A mass that is at least 10 centimeters is bulky. Very easy, easy to remember, biologically meaningful, easy to apply to any site. When you have a bulky disease, for this reason, especially in the past, before the PET scan era that allows us to define residual masses to be alive or not, containing alive tumor cells or not, we used to perform radiotherapy over bulky disease after chemo just to make sterile the inner part of the mass. Now we can be more precise and do it only when there are residual metabolically active cells within the mass. Even though the tumor is growing up so quickly, for the same reason we have already defined for aggressive lymphomas in general, it's curable. And indeed, in this case, it's highly curable, because in Western countries, we can reach up to 80% of cure rate in those patients, and even above 60% in limited resource countries when proper protocols are applied. So of course, not in a village, but if you go to a hospital and you can apply the proper chemotherapy, you do that. Important, the chemo is not the same chemo that you use in diffuse large B-cell lymphoma. So differential diagnosis is mandatory. Chemotherapy that you use for diffuse large B-cell is given every 3 weeks. In 3 weeks, Burkitt lymphoma is going down and growing up, going down and growing up. So you cannot cure. So you need a more dense chemo with chemo given at least weekly. So it's different. Same as to be in low resource setting. 2 notes, highly curable, but the 20% not responding to chemo is like treating a table. You put chemo on the table is not changing. The disease is totally resistant and growing fast. So it's a terrible, highly lethal disease. Second, the tumor is growing fast, is also going into apoptosis under chemo very quickly. So when you have a bulky disease and advanced stages, you have to be careful, because if you give intensive chemo immediately, particularly the monoclonal antibody, you risk tumor lysis syndrome, meaning that you are killing too many neoplastic cells very quickly, so you will have released in the blood of debris, uric acid, and so on. You risk renal failure. Okay, so need to be careful when giving the disease. This is, yeah.
Like in low-resource countries, let's say that they don't have sufficient money to get like a full regimen to provide to the patient. Is a combination between radio and chemo possible? As it is done for, I don't know, other solid tumors, or is that not effective?
It depends on the stage. You probably couldn't hear. We have a question here. If resources for chemotherapy are limited, radiotherapy can be given in association with some chemo. Yes and no, it depends on the stage. If you have a limited stage 1 mostly, you can give radiotherapy. If you start having some spread of disease, you cannot use chemo properly. And wouldn't be so cheap, actually, because facilities for radiotherapies are a little bit complicated. You will use less expensive drugs. Actually, some of the drugs we are using here are not expensive at all. I can tell you, but I'm under recording, but this is almost official, that, for example, in Kenya, but also in Tanzania, so the Eastern Africa, they get fake drugs from India. In India, fake drugs are commonly produced under patent from big pharma companies, but they do produce. They do also for hepatitis C virus, and most patients also in Europe are getting those drugs. They are clones. I don't know how to define. It's like fake watches, like fake everything. They do drugs very similar but never tested, and sometime in Kenya they buy. They cannot buy in the hospital, but they can buy for patient to take. They are free to take it on. Here, anyway, some images to show you what bulky means. and highly proliferating tumor. And to show you something that we will discuss very shortly, which means the localization in the facial district of the disease. Indeed, when dealing with Burkitt lymphoma, we have to recognize three different epidemiological clinical variants that we call endemic, is the common one, the one that we find in Africa, Central Africa, affecting children, 70% of course, in children below the age of 10, usually around 5 to 8. The sites are often mandibular, but then also gonads and abdomen. Why mandibular? It's not completely understood, because it would be the same for other cancers, but in mandibular, it's a site of hematopoiesis, so you have hematopoiesis at that age, is the age in which you have dental growing, you have some of stimulation, you can have inflammation at that site. So to play a role. Then you have the sporadic, which is Burkitt lymphoma, which we observe in our countries. Variable age can be young patients, can be older adults, and sites are mainly lymph nodes, GI tract, and gonads. Immunodeficiency associated, particularly HIV setting, we can have increased frequency of Burkitt lymphoma, and the sites are lymph nodes, GI, and gonads, but also quite frequently CNS. Burkitt lymphoma is one of the lymphomas most common in HIV patients. Even though the group is immunodeficiency associated officially, most authors, even the one dealing with Burkitt, they call it HIV associated, because the vast majority of patients are HIV in this case. Now, what about morphology? Actually, morphology is the same. So the three variants are just epidemiological, clinical different. They are not different in the pathology. Burkitt lymphoma is characterized by medium-sized cells. And what do they correspond to? Well, actually was very lucky. It was the pleasure to be at the microscope, actually at the screen, because the microscope was connected to a monitor with Karl Lennart. In 2009, Karl Lennart is the founder of hematopathology in Europe, basically, one of the major hematopathology, the biggest in the history, probably. And he showed us early centroblasts in normal lymph nodes. Honestly, very hard to see, but he was an amazing person. And Burkitt lymphoma, they do resemble early centroblasts, so the first stage of germinal center reaction. So you can also understand why proliferating so fast. This is exactly the proliferating phase of germinal center. The nuclei, you can see, they are not as open as we have seen. This is probably a centroblast. Not as we have seen in big centroblast in diffuse large B-cell lymphoma and follicular, is what we call reticular, a little bit more irregular, with many nucleoli. You can see they are up to 6. The cytoplasm is not abundant, but quite evident, and definitely basophilic. When you have cytological preparation, not histological, in cytology you can see little bubbles, optically empty vacuoles of lipids. You lose them at histology because of fixation, but you can document by immunohistochemistry, this was a study, it's not routine diagnostic, that lipidic metabolism is activated in Burkitt B cell. And probably those vacuoles of lipids are a sign of this metabolic switch. The growth pattern is overall cohesive, so you see cells are relatively close and well packed, one to the other. And we have very common mitosis, is highly proliferating, and a very, not 100% specific, but absolutely characteristic, you always see in Burkitt lymphoma. You see here we have a dark background, both for nuclei and the basophilic cytoplasm, and with these bigger white, very clear areas. So we define kind of starry sky pattern. This is given here you can see a little bit better of the dark bluish background with white areas, is given by macrophages that will clean up cells undergoing apoptosis, distinguishable bodies, so those apoptotic cells. So that cells, the little bodies dark inside. About immunophenotype, Burkitt lymphoma, a little bit like follicular lymphoma, is very consistent. Indeed, Burkitt lymphoma is 100% consistent. Any variation from the conventional phenotype would challenge the diagnosis. Burkitt lymphoma is positive for B-cell markers, try to guess, 19, 20, 22, 79A, IgM positive, and germinal center markers. No way you can skip them, CD10 and BCL6. On the other hand, BCL2 is always 100% of cases negative. So Burkitt lymphoma is highly proliferating but can undergo apoptosis. This will explain you the starry sky pattern with cells undergoing apoptosis and will explain the good response to chemotherapy. On the other hand, you have expression of MYC. MYC is the oncogene, is the master oncogene of Burkitt lymphoma. Actually, MYC was cloned starting from Burkitt lymphoma cases. Indeed, Burkitt is a good model because the first oncogene cloned was MYC in Burkitt lymphoma. And Ki67 is 100%. That's why for the other tumors we accept up to 99. So we have Burkitt lymphoma deriving from the early dark zone, from the early centroblast, highly proliferating area of the germinal center. The immunophenotype is coherent, is consistent with CD10 and BCL6, you see very easily recognized, and BCL2 obviously negative in the germinal center, some infiltrating T lymphocyte, positive acting as positive control. Here is proliferation index. As you can see, I failed to find any single neoplastic cell negative for MYC1. So very incredible. This is a terrific proliferation rate. Now, about the pathogenesis of Burkitt lymphoma. Why is considered a model? Why so particular? Basically, mostly we know about the pathogenesis. The molecular pathogenesis has been studied mostly in sporadic cases, while the etiology has been studied mostly in the endemic setting. Putting things together, we know that we have a multifactorial etiopathogenesis. We have ABV contributing, the chronic antigen stimulation, as we have now appreciated, is present in mostly lymphoid malignancy, and of course, specific genomic injury. First, ABV. What is ABV doing? Actually, the role of ABV is well accepted as an oncogene, as I mentioned, is recognized as a cancerogenic factor class 1 by YAR, so no doubts. However, in Burkitt lymphoma is quite peculiar because the latency type of ABV, you know that ABV can have different latencies, so express different molecules in different hosting cells. And in Burkitt lymphoma, you have no expression of LMP1 and LMP2, no expression of the oncoprotein, but just expression of EBNA1, sometimes EBNA2, and the microRNA. However, we know something for sure. First, it's expressed in 100%, virtually all endemic Burkitt lymphomas, 30% of sporadic, 50% of HIV-BL. This is not referred to serology, positive serology to ABV in the patient, it's just inside the tumor. We know that ABV infection, which is usually typical of adolescents in Western countries, is actually happening very early in peri-equatorial areas, below 5 years of age. So when the immune system is not mature. So in the majority of these patients, unfortunately, the infection is not completely resolved and ABV can remain latent in memory cells and determine them to be immortalized. So we have a polyclonal population of immortalized EBV positive memory cells. Of course, those memory cells, by chance, can be affected by antigen and can enter again the germinal center, proliferate again, and maybe undergo somatic mutations and translocations. Here is EBV in the case of Burkitt lymphoma, so it's very evident. Indeed, we believe, I say we because I'm involved in the research, that a higher percentage of cases of what we currently consider EBV positive did experience EBV at a certain point of the neoplastic transformation. Indeed, it's called hit and run hypothesis, since the episomal DNA of EBV cannot replicate as fast as those tumor cells. By each replication phase, we will have dilution of EBV. So it may happen that when you see the patient, you don't see EBV, but EBV was there when transformation initiated. The second factor contributing to Burkitt lymphoma, even though we don't have mechanicistic evidences, is malaria. As first evidence, is an epidemiological evidence, malaria just occurs exactly where Burkitt lymphoma occurs. It is not a matter of latitude, because it's also more specific. If you go in a precise latitude and you go, for example, higher and higher in mountains, mosquitoes will disappear and Burkitt lymphoma will disappear as well, meaning that the relationship is at least reasonable. How does malaria interact with lymphocytes? Please never tell me that the plasmodium is going into lymphocyte. There is still a student complaining that she couldn't pass the exam after saying that with me. But I don't consider that the commonest infectious disease in the world is unknown to my students. At any level, any exam type, whatever, even though we are discussing physical education, you have to know where malaria is going. Okay? But malaria can activate proliferation of B cells, of course. And we have EBV immortalized B cells, so can promote proliferation of EBV immortalized cells. Further, chronic malaria in the real life is not just what we study. Okay, there is malaria, there is hemolysis, malaria is a chronic disease. Those children get malaria every night from mosquitoes, right? For years. We have a chronic condition, and cytotoxic T cells are chronically inhibited by the process. So, once more, the B cell clone, the immortalized B cell clone, EBV clone, has lost the control from T cells. And generally speaking, malaria will give a chronic stimulation to our B cells, favoring re-entering germinal center and possible occurring of genomic lesions. It is currently thought that arboviruses to play a role as well due to the epidemiological evidences, same areas and even epidemic foci of Burkitt lymphoma in villages few months after epidemic foci of arbovirus infection. However, no study could demonstrate the presence of the virus inside the lymphoma, and there are no experimental models for that. However, it's certainly an interesting starting point for research. Last but not least, Euphorbia tyrukali is a plant very common in the environment in Eastern Africa, and is a plant with several properties. First of which, the latex, the lymph, which is a latex lymph, is a little bit white. I also mentioned the Christmas star, I don't know the English name for the plant that you see in Christmas with the red leaves. If you break by mistake a leaf, the lymph is white, it's a little bit of latex. Actually is antibacterial. So when the little kids, they get scared by playing in the countryside, mothers or whatever, or whoever they are, they put the latex from this plant as antibacterial. Second, this latex is similar, I don't know, or at least the Italian about among you, we have a glue, it's called Vinavil, is whitish, and when drying up, it becomes like a little gummy, and kids like to play with that. So with the lymph of this plant, kids, they play. Unfortunately, this lymph, it contains a forbol ester, which is a super potent clastogenic, so breaks DNA. If you expose lymphoblastoid cells, so ABV-infected lymphocytes, to this forbol ester, in a few hours, just 48 hours of exposure, you have breaks everywhere in the DNA. So it's a very potent inducer of mutations and translocation to which these children are exposed. Altogether, we end up with MYC translocation. But in Burkitt lymphoma is not 60-40, is always with immunoglobulins that are most often AV chain in the translocation 8-14, MYC is on chromosome 8, AV chains of immunoglobulins on 14, or as alternatives, genetic alternatives, but functionally identical with light chains, with IgK or Ig lambda. So MYC translocation is a major event. However, we have been thinking that MYC is doing everything because MYC is sufficient to transform cells in experimental models. If you activate MYC in centroblast, you end up with something in between lymphoblastic lymphoma and an aggressive lymphoma in mice, but differences in histology are allowed in experimental models in animals. So it's considered MYC sufficient for lymphomagenesis. So we actually neglected Burkitt as a simple karyotype, so you can easily see only MYC translocation. But most recently with deep sequencing, it was found that other mutations can occur, particularly downstream the BCR signaling. Once again, BCR signaling is a key pathway to be affected by genetic insults in lymphoid malignancy, and in this case specifically, the genes ID3 and TCF3 can be mutated, determining tonic activation of BCR signal. Very interestingly, if you study sporadic and endemic cases, let's make it more simple, ABV positive and ABV negative cases, you can see that those mutations are much more frequent when there is no virus and less frequent when you have the virus. Meaning that even though we don't know exactly how, the virus is mimicking, determines, or probably just associated with a richer antigen stimulation in African setting. So the cell do not need neoplastic cells, BCR mutations, but they have the virus and chronic antigen stimulation. So we define it chronic antigen stimulation because it's probably the microenvironment to support the neoplastic cells until MYC will do the big job. Is MYC always 100% of cases present? Little bit the same story that for follicular lymphoma BCL2. Here is even more rare. Was recognized very recently. I would say that 5% we had to give an amount, but it's very, very rare. We have studied also further. This phenomenon is very rare. What is interesting on the pathogenetic point of view is that in those cases in which you don't have MYC, you find the MYC-N. Just to refresh, MYC is what may be in your life you have heard about like c-MYC. The name c-MYC doesn't exist since 20 years. Okay, c-MYC doesn't exist since 2000, more or less. It's MYC. This is MYC. But there are other family members like MYC-N and MYC-L. They do very similar, probably less important in the development the genetic of cells, but they can vicariate each other. So in these tumors, we found NMYC to be expressed and exert the same activities. So how do we differentiate diffuse large B-cell and Burkitt? Just go one by one with the elements we need in WHO. Clinically, this is easy only for Africa, maybe. When you have little children, the history, the location, this helps, of course. But obviously, in Africa, you can have sporadic Burkitt, so without connection with those pathogens in adults, or you can have diffuse large B-cell. Actually, the LBCL is very common in Africa. After classes or even in general pathologies, they think in Africa there is only Burkitt. Burkitt is the commonest in children, but then overall diffuse is the commonest lymphoma. But then we go to morphology. Burkitt lymphoma has that specific morphology with the early centroblast, the medium-sized cell, reticular chromatin, cohesive growth, starry sky. If it's atypical, get the suspect of diffuse or the high-grade lymphoma with double hit. The phenotype, Burkitt never expresses BCL2 and IRF4. So if you test them and they are positive, this is diffuse. Maybe resembling Burkitt. In the past, there was a category, Burkitt-like, now it's not anymore. It's the grade B-cell lymphoma, but it's not a Burkitt. This is important for treatment choice. Genotype, if you have translocation of BCL2, if you have translocation of BCL6, if you have non-IgG MYC partners, this is not a Burkitt. If you have complexity, this is not a Burkitt. You go back to the previous chapter that we have been discussing today. Any question about Burkitt? Not here. Anything at all? Just to take time, do you know where is the Oliva room? Next time we won't be here. We are in another place. Yeah. We insist to come. If you want to stay home, I will not complain too much. Oh, Iernerio? Where?
In the anatomy department.
Oh, it's in the anatomy. So
Yeah.
it's the anatomy.
Yeah, you enter the department, then you go on the right, and the last room before the huge door is that one.
Okay. Anyway, it's in the anatomy.
Yeah.
Okay. Oh, I used to go a lot then. Okay. If there are no questions, we will discuss that later. I think we can move on to mantle cell lymphoma. Before going through mantle cell lymphoma, just to refresh, because we've been focusing on germinal center a lot. Why? Because germinal center is where most lymphoid malignancy do originate. Even when you see post-germinal center, sometimes you have the event in the germinal center because somatic hypermutation and class switch are major genetic events that can cause also mistake. So the mantle zone is the portion of secondary follicle surrounding the germinal center. And you can easily recognize because it's the dark zone, because it's composed by small lymphocytes, mostly naive, some memory, they are exactly the same looking, so you cannot distinguish morphologically. So small lymphocytes, very dense chromatin, very thin cytoplasmic ring. So mantle zone surrounding the germinal center. Mantle cell lymphoma is the tumor deriving from mantle zone. Mantle zone is composed by small lymphocytes, the very obvious mature lymphocyte that you find also in the peripheral blood. So by following the principle of cellular counterpart, you can imagine that mantle cell lymphoma is a small cell lymphoma, mostly, and when you diagnose a mantle cell lymphoma, you are facing a small cell tumor And this led in the past to the big mistake to consider mantle cell lymphoma as a low-grade lymphoma. When I mentioned the classifications in low-grade and high-grade, very simplistic one, probably the biggest mistake was including mantle cell lymphoma inside the low-grade because of the low aggressiveness at histology. Small cell, very quiet. Indeed, if you look at the survival curves, mantle cell lymphoma is probably the most aggressive among B-cell tumors. We don't have time, but T-cell lymphomas, they behave as badly, but among B-cell is the worst. So considering it an indolent lymphoma, low-grade lymphoma, is really big mistake because most patients will die. See, 50% of patients are passed within 2 years and a half. So it's really, really an aggressive disorder. Mantle cell lymphoma is occurring in 5 to 10% of cases of all lymphomas. Middle age, so around 60, once again. Male to female, 2 to 1, very similar to follicular. The disease presents affecting lymph nodes, spleen, very commonly bone marrow, even more commonly than with follicular lymphoma, so 70%. So immediately you understand that more than 70% are stage 4. So very advanced stage in most instances. Very commonly affected the peripheral blood, so leukemic phase, leukemic presentation of this lymphoma. GI tract, 30%. Mantle cell lymphoma is very common in GI tract, and we have seen already that GI tract is a common site. It's common for diffuse, it's common for Burkitt, it's common for mantle cell. Can we say something more? When dealing with follicular lymphoma, the jejunum, the variant, very indolent, very, let me say benign, even technically not benign, but patient rarely die for that lymphoma. The tumor is not infiltrating really in all the deepness of the structure, so chemo will resolve with what we call restitutio ad integrum, so the complete restoration of layers of the GI tract. Differently, when we have diffuse Burkitt and mantle cell, we have a big, big risk. Because those tumors, highly aggressive, they tend to involve all layers of the visceral. And after you give chemo, those are aggressive, can be destroyed quickly. You risk perforation. So you risk acute situation and peritonitis, very bad situation. You can imagine a patient with a lymphoma under chemo, neutropenic for chemo, just with a hole in the intestine. Very bad. So even more carefully here that we bulky. So GI tract lymphomas, very carefully when you give chemo. Waldeyer ring also can be affected. Concerning morphology, we can have different growth patterns. We can have what we call mantle-like. It means that the mantle zones are enlarged, just surrounding the germinal center. Can be nodular. This is very similar of what we described for marginal zone lymphoma. So when you have growth inside the follicle, invasion of germinal center, at the end you will have a nodule of mantle cell lymphoma. And by time, it will become diffuse with fusion of different areas. In the cytology, we have different morphology. The most common, which we call classic, is composed by small cells. quite often the nuclei, you see here, even though I said that they correspond to very quiet, naive memory cells, nuclei are not perfectly rounded, but they are indented, they are cleaved. That's why in previous classification it was considered a centrocytic lymphoma, because those cells are not very easy sometimes to differentiate from centrocytes. So overall, the differential is between this tumor, follicular lymphomas, grade 1, 2 mainly, and what we will study next time, the lymphomatous pattern of chronic lymphocytic leukemia, which is small lymphocytic lymphoma. We have already, however, some cases in which we have marginal zone-like morphology, meaning that cells are a little bit bigger with a little bit more of cytoplasm, so the differential would include marginal zone lymphomas. When they are not cleaved, not so evident the cleavage, they are more rounded, they are more similar to CLF. And we have a blastic, also called blastoid variant. The blastic variant, cells are a little bit bigger, nuclei not so dense, and the differential would include also tumors derived from precursors, so lymphoblastic lymphoma. Blastoid morphology is the only one associated with a specific prognosis. Those are more aggressive. When the intestine is involved, we can have what we call lymphomatoid polyposis, so those polypoid lesions. So be careful not to confound with, of course, epithelial lesions, and go for biopsy and immune. Bone marrow involvement, 70% of cases. Like for other indolent lymphomas, like follicular, tend to be paratrabecular. So neoplastic cells tend to go close to bone trabecules. However, can be sparse, diffuse, or massive in the bone marrow. Here we see some patterns with the germinal center maintained and the growth outside. Diffuse, of course, we have a diffuse pattern here. You don't distinguish other than the neoplastic population. Note that is quite homogeneous. Now the difference with diffuse large B cell, in which we have polymorphic. This, like maybe Burkitt, even though cells are different, be clear, is quite homogeneous, very similar one to the other. Some histiocytes and nodular pattern when you have follicles involvement, you know those follicle. Difference is that the population tend to be homogeneous, even when cleaved. Centrocytes are very irregular. Then you have centroblasts. So morphology, an expert eye can differentiate. Of course, can be tricky. Here the blastoid variant. Is there anything that comes to your mind? Cells are not as big as in diffuse, but the features of a quite activated cell with completely open chromatid, the nucleoli, and if we had time, but we don't, we will see maybe in hematology to see lymphoblasts, this would resemble an immature neoplasm. Okay? Be very careful. They are usually homogeneous. But as in biology is always possible, you can have also cases in which you have some cleaved cells, some more rounded. You see those are irregular with cleavage. Some are bigger. Polymorphic variant can be difficult to diagnose because, to be very scholastic, one of the features of mantle is being relatively homogeneous. So the polymorphic, even to hematopathologists, if they are not really skilled, is something they really don't like. So we can move to phenotype and genetics to help our diagnosis. And on phenotype, we now have something a little bit new for us, because we have the B cell marker, yes, 19, 20, 22, 79. We don't have, of course, germinal center. CD10 and BCL6 are negative. We don't have marginal zone. IRTA1 is negative. But we have expression of CD5, which is atypical because CD5 is known to be a T cell marker. Actually, immunologists would claim that there are rare B cells. It's a particular phase of B cells in the peripheral blood. They do express CD5, and we'll see next time that also chronic lymphocytic leukemia is CD5 positive. So this marker is very important because basically we have two tumors, small cell tumors expressing CD5, B cell tumor, mantle cell and chronic lymphocytic leukemia. Where's the difference in CD23? Here is negative, in CLL we'll see it's positive. So those markers are really interesting for us for the differential diagnosis. On the other hand, follicular would present CD10 and BCL6, marginal zone would present IRTA1. Here you see also cyclin D1. Cyclin D1 we'll see in 1 minute because it's related to the genotype. BCL2 is positive. Oh, once again is positive. Be careful, BCL2, I mentioned describing B cell biology, is expressed physiologically in all lymphocytes outside germinal center. So there is nothing weird in mantle cell lymphoma expressing BCL2. It's not rearranged, it's not translocation, nothing. It's BCL2 is normal for mantle cells. Follicular dendritic cells can be present. You usually see them in the nodular pattern because, of course, they are reminiscent of the normal germinal center. Okay. But now, getting back to this cyclin D1, in the genotype, the hallmark, the genetic hallmark of mantle cell lymphoma is translocation 11, and once again 14. So IgH, heavy chain on 14, BCL1 encoding cyclin D1 on chromosome 11, overexpression of cyclin D1. You can test it by immunohistochemistry exactly as you do for BCL2. So this is a clear example of mantle cell lymphoma in which we have CD5 and cyclin D1. But you can also see BCL2 staining the neoplastic population, but not the residual germinal center, the spare germinal center in a mantle zone pattern. Follicular dendritic cells, we usually check them to see whether we have nodules, we don't have nodules, what the nodules are made of. Because when you don't see proper centroblast and centrocytes, maybe it's just not a secondary, a primary follicle, right? We cannot distinguish in a diffuse pattern. So the follicular dendritic cell measure helps us to rebuild the follicular structure in a lymph node effaced by neoplastic population. T1114 with BCL1 is the major genetic event of mantle cell lymphoma. You are now familiar, BCL1, BCL2, BCL6, all of them cloned in neoplastic cells. So B-cell lymphoma, gene 1, 2, 6, and whatever. BCL1 is cyclin D1. Cyclin D1, like BCL2, is likely to be translocated due to a mistake in VDJ editing rather than later on. And in fact, this is a tumor resembling naive cells, so before germinal center reaction. And as for follicular lymphoma, we can use the expression of cyclin D1 and the translocation both for diagnosis, mainly for differential with other tumors, because cyclin D1 translocation is absolutely specific for mantle. While BCL2 translocation is also in diffuse, BCL1 is mantle cell stone, but also for minimal residual disease monitoring. On the pathogenetic point of view, cyclin D1 is affecting the cell cycle. So basically cells cannot stop growing, and interestingly, other checkpoints in the cell cycle can be affected by mutation in mantle cell lymphoma, like ARF, CDK4, RB1, and of course the ubiquitous, I would say, affected in human neoplasia, TP53. Now, we have seen the phenomenon in follicular, we have seen in Burkitt. Of course, you expected to see how much frequent is to find cyclin D1 negative mantle cell lymphomas. Actually, those are probably a little bit more common than in Burkitt, so at least 10% you can find. But what's happening here is that you have, like for Burkitt, a very close gene, in this case is cyclin D2 and cyclin D3, to take the role of cyclin D1. So basically those tumors are exactly identical to cyclin D1 positive. If you perform a gene expression profiling, once again, you see that profiling of those cases, even though without the major oncogene, they are exactly resembling the conventional mantle cell. You see all red here, all the genes that are affected in mantle cell, they are in cyclin D1 and 3 positive cases. So not a big event for the pathogenesis of the tumor. Of course, important for us, because when you test negative cyclin D1, you cannot exclude the diagnosis. So super positive predictive value, when it's cyclin D1 positive, it's mantle cell lymphoma, 100% sure. If it's negative, you go further in your differential. On the other hand, you can use, in those cases, the expression of SOX11. SOX11 is in fact a gene quite consistently expressed in mantle cell lymphoma, even in the cyclin D1 negative. You can see more than 90% overall and 100% in this pivotal trial in cyclin D1 negative, while it's absolutely occasional in other B-cell lymphoma. Here you see it was positive in T-cell lymphoma, so something completely different. You don't usually make a differential. And in Burkitt lymphoma, once again, something not really entering the differential. 1 out of 4, by the way, not so common. So it's a very reliable marker for differential diagnosis, SOX11 in mantle cell lymphoma, even when negative. Other findings. Mantle cell lymphoma is very similar to naive cells, right? Very nice. So I expect to have unmutated immunoglobulin genes. So not affected by somatic hypermutation, because those cells never underwent germinal center reaction. However, we have a percentage of cases, it's not common, not rare, would say 20%, okay, they are mutated. Other mutation, I mentioned TP53, but we have also other genes, Notch1 and Notch2, BIR3, cyclin D1 itself, MLL2, mixed lineage leukemia 2, which is mutated also in follicular, and other. Don't really focus on those, just remember that you have additional, and TP53 is included. If you look for the molecular profiling, looking for prognostic features, mutation or whatever, actually proliferation is the main driver of prognosis. The highly proliferating cases, they behave badly. They are really, really bad behaving. And indeed, it's kind of continuous, not really a cutoff, highest proliferation, lowest proliferation. This is not, of course, possible in everyday routine, but with Ki67, you can have, with Ki proliferation index, at least a guide. However, look at the survival curves. 50% of patients already died before 2 years, all died in 3. So still we have bad lymphoma. Overall survival, look, a live patient at 10 years, and those are age 60, right? They are very few, occasional. So this is a very, very badly behaving cancer. What else did we observe by, I would say, high throughput genomic studies? From high throughput genomics, we find a subgroup of tumors, the ones with better prognosis. They were different. And so it prompted, first of all, a Spanish group, very strong, Barcelona group led by Elias Campo, very strong in mantle cell biology, to study deeper those tumors. And those tumors, actually more indolent, they were characterized by bone marrow infiltration, but very scant nodal involvement. Those are actually, you can see, indolent mantle cell lymphoma very rarely present with nodal enlargement, while classical mantle cell lymphoma, almost all patients will have lymph nodes somewhere. They may have splenomegaly rather, and peripheral blood, marrow, and obviously marrow came first, and peripheral blood. If we look at genomic profile, what's the big news? That indolent mantle cell, they mostly present mutated immunoglobulin. So they are cases corresponding at the end to memory cells, because they are, of course, not within the germinal center. While classical are mostly resembling naive cells. So difference is not 100 to 0, okay? So it's not indolent is the mutated, classic is not. It's 70% versus 20, so it's highly significant, but important. On the other hand, indolent mantle cell, they have one or no genetic lesions. Classical mantle cell, 90% of cases, more than 2. So a more complex genetic, okay? And prognosis, 5 years, half already passed versus 0, almost a benign condition. Those are very indolent. I can tell you that indolent mantle cell lymphoma, they don't receive chemo. They are just followed up because of the strikingly good prognosis. And indeed, when you go for genetic study, you see that they are different. They are SOX11 negative. So the strongest marker for mantle cell lymphoma is negative in here. So the biology of those cells is different from that of molecular of that of mantle cell. And in fact, if you consider overall the few cases of SOX negative in the mantle cell overall population, you can see that the prognosis is quite good because they are mostly represented by indolent. If it's true that T1114 can happen, does happen in the bone marrow as a mistake in VDJ editing, it's not surprising that exactly as it happened for T1418 in follicular lymphoma, we can have a monoclonal lymphocytosis carrying cyclin D1 and being asymptomatic. So we have cells that are absolutely consistent with mantle cell lymphoma, but just scattered few cells. The peripheral blood, no splenomegaly, no clear obvious infiltration in the bone marrow, so it's not an indolent. It's really same cells actually than classical mantle cell lymphoma. They are SOX11 positive, but just few of them going through the body or maybe present in the marginal, in the mantle zone of scattered follicles in a lymph node. Exactly the same principle. This is in situ mantle cell lymphoma. Here the name was not changed to mantle cell neoplasm because the significant being mantle cell lymphoma more aggressive overall, it's not so clear that this is a benign condition, but anyway, it's the corresponding tissue counterpart. So overall, the hypothesis is that T1114 would happen in the bone marrow, so naive BCL1 positive cells circulating or in the mantle zone of scattered follicles over years. You see, many years may give rise to mantle cell lymphoma, and even by accumulating mutation, you can move from classical mantle cell lymphoma to blastoid or pleomorphic, the variants that are a little bit more puzzling in clinic for differential and for treatment. So overall, cyclin D1 positive cells in situ mantle cell lymphoma going through indolent or conventional mantle cell lymphoma with more complex karyotype and more aggressive behavior.